My name is Terry King. I'm the Chief of the Division of Breast Surgery at Brigham and Women's Hospital and Dana-Farber Cancer Center in Boston, Massachusetts. ACOSOG 1071 was a large single-arm prospective trial designed to assess the feasibility of sentinel lymph node biopsy in patients who started out with clinical N1 disease and converted to clinical N0 disease after preoperative chemotherapy. We had avoided using sentinel lymph node biopsy in this population for many years because we were concerned about the patterns of response in the axilla, and we didn't know whether the sentinel lymph node biopsy technique would adequately stage the axilla. So the primary endpoint of 1071 was the false negative rate of the procedure, and the investigators set a cutoff of 10%. That is, if the false negative rate was less than 10%, we would be comfortable omitting axillary node dissection in the setting of negative sentinel nodes after chemotherapy in women who started out with clinical N1 disease. So the trial successfully accrued, I think, just under 700 women. And when reported out, however, unfortunately, the false negative rate for the entire population was not less than 10%. It was right around 12%. And this was obviously disappointing because we were hoping to be able to avoid the morbidity of lymph node dissection in patients who had an excellent response to preoperative therapy. The investigators, however, went back to examine different factors that were associated with the false negative rate in the study population. And they identified that there were some techniques of doing the sentinel node that were important. So the protocol was written to encourage surgeons to use dual tracer technique, both in radioisotope and a blue dye, but it was not mandated. The protocol was also written to encourage surgeons to remove 2 or more sentinel lymph nodes, but this was not always achieved. There were also some patients on the protocol where the pathologists evaluated the lymph nodes with immunohistochemistry, and therefore, if you counted smaller volume disease in the calculations, that also impacted the false negative rate. So in essence, what the ACOSOG 1071 investigators concluded was that if you used dual tracer technique, and if you removed at least 3 sentinel nodes, that the false negative rate would be safely under 10%. Now, as we thought about how to apply these clinical trial data in our practices, many different groups adopted different techniques. Our center, we initially started out mandating, again, the use of dual tracer and the removal of at least 3 sentinel nodes. These nodes would be examined intraoperatively, and if all of them were negative intraoperatively, we did feel comfortable omitting axillary node dissection. Of course, the caveat here was that we did have to explain to patients that we did not have any data on local regional recurrence in this setting. We were simply basing this decision on the fact that we believed the false negative rate was low enough that it would not impact local regional failure. Other groups adopted different techniques. The MD Anderson group popularized what they called targeted axillary dissection, and that is they would clip the biopsied lymph node at the time of diagnosis, and then when going to surgery, they would perform radioactive seed localization of that biopsied lymph node in addition to the sentinel lymph node biopsy procedure, and they reported that this was also associated with very low false negative rates. Our group has since also adopted that technique. There is a learning curve, certainly, with clipping nodes and placing seeds in nodes. But again, we now have, our practice now is that we still use dual tracer. We do clip our nodes. We use radioactive seeds to localize those nodes at the time of the sentinel node procedure. And we mandate removal of the clipped node as well as 2 sentinel nodes. And if all of those are negative on intraoperative analysis, then we are comfortable omitting axillary lymph node dissection. The important point, though, to remember is all of these techniques and all of the conversations over the last 5 years have all been about minimizing false negative rates. We still await data on the actual local regional recurrences in the axilla in women who have avoided lymph node dissection. These data are starting to emerge. There's some data from our colleagues in Italy demonstrating local regional rates to be very low and no different than in women undergoing node dissection. And there's some single arm data coming out of Memorial that will be presented at San Antonio in 2020, also demonstrating in their hands very low rates of isolated local regional recurrence in women who would have been qualified for 1071, found to have negative sentinel nodes intraoperatively, and did not undergo axillary node dissection. And we will continue to see outcomes data reported, and we will hopefully continue to see, again, not only improvements in our ability to identify sentinel nodes and omit axillary dissection in patients who have an axillary PCR, but also more data supporting the long-term safety of this approach for our patients.